We already managed one teaching point. Here is another one. And of course, casting type calcifications, DABs on a mammogram, can be in any age. But somehow, we have this impression that quite many young women have it. And that's not fun. I tried to give an explanation for it. Let me just show you 2 cases. 29-year-old woman felt a thickening in the upper outer quadrant of her left breast. Here is the mammogram. Very easy, unfortunately. You see several AABs and then large number of casting type calcifications, indeed fragmented casting type calcifications. And they are here, and they are there, and they are just about everywhere. At the chest wall, I certainly feel sorry about the patient, but I feel equally well empathy with the surgeon because the calcifications can be seen here, here, under the skin, everywhere. How are we going to handle this surgically? No skin-sparing mastectomy, right? Not because the calcifications are here. Even if the calcifications stopped here, there would be carcinoma all the way. This is one young woman I showed you. I show another one. I went to visit my friend Bruce Porter in Seattle, and I don't know why, I met 3 women, very young, with casting type calcifications. And here is one. You always look at a mammogram from a distance. No calcifications in the other breast. Young women may have big lobes, and you look at this mammogram, and then you say, this is fragmented casting, this is dotted casting. They are pointing in all directions. There may be skipping stones. What a sad case. And then Dr. Porter did MR. You may be influenced by the pathologist by saying, oh, here is an invasive carcinoma. Please, this patient has 2 invasive carcinomas. This one and this one, a tiny AAB. Why do I show this case? Because Dr. Porter did whole body MR on her next week. Would you mind looking at this large number of lung metastases? Axillary lymph node metastasis? Supraclavicular metastasis? Multifocal AABs, not a good news. But this is going to jeopardize her life. Does she have a 50% risk of dying from breast cancer when she had multiple lung metastases? Unfortunately not. She dies from breast cancer. Did she die from a 14-millimeter invasive carcinoma? No. She's going to die from that 10-centimeter DAB and an enormous tumor burden that it means. This one. So what do you think? I ask you a question. What could be the explanation for women, especially young women, having casting type calcifications on a mammogram and dismal outcome? I have a suggestion. The mother's ovaries were exposed to pesticides, radiation, in utero exposure to designer chemicals, and unfortunately for medical reason, justified direct radiation of the developing breast tissue. This means that the pesticides or radiation alters the egg, and then comes the sperm. And about 20, 25, 30 years later, she gets the casting type calcification type breast cancer. While I was running my live courses in the United States, I was talking about pelvic CT. Then one of the colleagues, surprisingly, jumped up and got very excited and told, "Don't tell me that. I have a 12-year-old patient who, for whatever reason, we still don't know the diagnosis, very frequently gets bellyache. And whenever the parents bring her to the emergency unit, this is exactly what she gets. This girl already had 27 pelvic CTs. Can you imagine what her ovaries look like? Be very careful, please. Pesticides, the groundwater. How many stories do you hear in the United States? What the groundwater looks like and how much damage that causes for the population. I'm going on. DDT exposure in utero. We are very much troubled by COVID. But let me refer to the swine flu and the different viral exposure. Suddenly DDT walked out of the storage places. Independent of maternal history of breast cancer, 4 times fold increase in the daughter's risk of breast cancer. May I have a very humble suggestion? When you have this picture in front of you, and it's a very young woman, and she has the casting tape calcifications, try to be epidemiologist and ask very gently intelligent questions. Where did you live? Were you brought up in? I don't want to mention a country that was in a huge war and dirty bombs were dropped. There are so many young women having breast cancers and very aggressive cancers. Just look at the mammogram. Look like this. I have another interesting comment as well. Pregnant women, life dangers, high blood pressure, whatnot. And it used to be praxis in medicine that they got diethyl stilbestrol shot, high dose. The children, when they were 17, 18, 20, 22, got very aggressive genital cancers, boys and girls. What I want to tell you, the exposure is today, 20, 30 years later, the negative effect comes. This is exactly what I'm talking about. Now, it's not enormously high dose of estrogen. I'm talking about this one. In this very particular subtype of breast cancers, ask whether the mother was exposed to ugly chemicals. The American colleagues certainly remember this. Dear colleagues, this is DDT. DDT right into the hair of this little girl. Smoking and DDT. The crop duster. Think about it. Do you think that this has gone away? No, it didn't disappear. This happened in Tunisia. It happens today. You open the television and you see that the people in mosques and the streets of China, they are doing this. Is it really effective against the virus? Question mark. Are we causing enormous trouble for the next generation? Question mark. Be an epidemiologist. Very intelligently ask them questions. That's the reason why it's a stem cell carcinoma. And that stem cell carcinoma is growing so fast, it's producing so many cells, and that's why it's resistant to radiotherapy and chemotherapy. I'm showing this slide again. We had an interesting experiment. The Swedish Society of Surgeons collected 500 so-called DCIS cases from the country. It's a huge material. Patient charts and their mammograms. And they were kind enough to send me all this material. It was about 2 tons. I didn't know the outcome. I didn't care about anything. Can you imagine? This is quite a lot of work to go through. And I looked at their mammogram and I classified fragmented casting, dotted casting, intracystic papillary carcinoma, galactographic case, fragmented casting, dotted casting, whatnot. And they were kind enough to publish. Their conclusion was, and mind you, All these 500 cases went through the usual dogma, radiation, all of them. When Laszlo told the word casting, there was recurrence despite radiation, 16 times higher than in any other group. Radiation doesn't work. Why do you send it? Young woman, 39. Next year, she would have received an invitation to mammography screening because since 1977, I have been screening women from 40. The American Cancer Society still doesn't recommend it. Our randomized control trial showed significant decrease in mortality in age group 40 to 74. You are not allowed to split into age subgroups because then you lose the statistical power. You don't have enough number of person years. What do old men deciding and writing the guidelines? They split it. And they don't have enough statistical power in 40 to 49, and they say, don't screen 40 to 49. I'm very much against it. I don't think those aging men sitting behind the desk should decide the fate of a young woman. She is 39. She felt the thickening. This is the key word, thickening. And the second is calcifications fill most of the right breast. Fragmented casting, dotted casting, that's necrosis. That's DAB. That's palpable. That's very extensive. I am very sad. She comes from a region with heavy industry. Does it go all the way to the nipple? Always does. Fragmented casting, solid cell proliferation, micropapillary cell proliferation, common denominator, necrosis. No good. It goes down to the TDLUs. That's why you see the crostone-like calcifications as well. Cancerization of the lobule. Let's go to the nipple. Here is the nipple. This is the nipple. This is the areola. If these are in ducts, and of course, where else? Why don't they point in this direction? Because this is neoduct genesis. That's why. And you don't like grade 3 carcinoma cells right there where the epiplexus is. You prove the obvious. Here is the bad news. If the casting type calcifications, that is bad enough, not only associated with an AAB, but that AAB is poorly differentiated. That's double trouble. What do? Neoadjuvant chemotherapy, of course, because we never heard about this, that is stem cell carcinoma, or we don't believe in it. Poor woman goes through hell. 4 months later, they do mastectomy, as they should. They remove the axillary lymph nodes, and you can see that the cancer was somewhat influenced by chemotherapy, but don't tell it died. Not even the AABs died, because 14 millimeter, 3 millimeter, 1 millimeter AAB survived neoadjuvant chemotherapy. And of course, this was simply laughing at it. There were 2 nodes positive and lymph vessel invasion despite neoadjuvant chemotherapy. This is a viable carcinoma, AAB. And these cancer cells are really sending out a message. These are within the lymph vessel. Now we know that chemotherapy is not going to work. So what is she going to get? More chemotherapy. Excuse me if you experience that I'm sarcastic. I'm actually angry because this doesn't make sense. You just torture the patient. Oh, we should irradiate as well. Oh, why don't we try a little Arimidex? She accepts everything because she has 2 kids. Deep venous thrombosis and all kinds of torture. 40 months later, sharp pain in the left shoulder. Despite all efforts, She died from breast cancer. I'm leaving that teaching point because you have cases, and I already sent you one case from Kurdistan. The title of the video was Tragic Case. I'm changing gears, and the next teaching point is going to talk about what I'm telling all the time. It's the major lactiferous duct and its branches that are diseased. It's ruled out that the disease is confined here and it doesn't touch the major lactiferous duct. She is 81. Sometimes we radiologists are lucky by being able to show the calcifications all the way to the nipple, and that's exactly the case here. So she has a huge palpable lump, certainly an AAB full of DAB. Fragmented casting type calcification, so I'm not even going to ask you. Solid cell proliferation, correct? Neoduct genesis, tons of disease. But this is what I wanted to show you. Both the MR and the mammogram show that the malignant type calcifications are all the way down to the nipple. There is more to it. Here are the malignant type calcifications. CC projection. You can read histology at this time point. This one has the lymphocytic infiltration and desmoplastic reaction. This is normal. This is distended. This is pleated. This is pleated, 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 normal. This is cancer. There is something more interesting here right under the skin. Did we see it on the mammogram? We shall see soon. Yes, it's here. Ultrasound saw it. Satellites right under the skin. This is the skin. This is a 3D picture of this satellite. This was the big carcinoma full of casting as well. Did we talk about solid cell proliferation? Yes. This is the casting. Central necrosis. Fragmented casting. She as well had poorly differentiated multifocal invasive cancer. That doesn't change the teaching point that whenever AAB is associated with DAB, in 64% of the cases, they are grade 2. I don't think they have anything to do with each other because this is grade 3 and this is grade 2. The mammographic image, the imaging biomarker is different. Why is it so? I don't know. We are still at this topic that the carcinoma comes down all the way to the nipple. She's 51. She felt a tiny little hard lump in the axillary tail. Not this time. This was her previous examination, and I'm showing it to you that this is harmonious, normal CC and MLO projection. But at next screening, when she feels something here on the Milky Way, you are certainly not going to miss something high up in the axilla, namely the casting type calcifications. So she draws your attention to here. But of course, your attention is here, and then you want to have more magnification and even more magnification. And suddenly you see that there are too many ducts high up in the axilla. No, women don't need ducts in the axilla. But then you follow and follow and follow, and then you see that they are just marching downward. No, I don't care about this kind of MR. Mammogram was much better. This is the tiny little thing which she felt. Yeah, that's an AAB. MR was good because it found the cancer in the other breast. Sure. But when concerning the right breast, this is the extent of the disease. And the automated breast ultrasound shows the palpable little lesion. Conventional ultrasound, so what? It's right under the skin. It has nothing to do with the casting. And you get an invasive carcinoma, but it's much more important to spear this area. And then you got this, namely the casting type calcifications, already at this time point you say, this proves my original idea that this is a new duct high up here. Doesn't make sense that there are so many large ducts there. And here is the histologic confirmation, already in a core biopsy. We can look at the left breast as well. Congratulations, MR. I still don't know where you found the cancer, but actually it's going to be somewhere here. Sure. We'll take care of that one too. That's invasive AAB. Let's go for the right breast and stick to the teaching point now. We were high up in the axilla here, and Laszlo wants to tell you that it went all the way down to the nipple. So here is a large section mastectomy specimen. Stand up here so we can view it much better. Now, there is one AAB, one of them she felt. This is smaller. That's great. This one is this one is that. We are done. Multifocal invasive AAB. But you see, the pathologist says, watch out, there is carcinoma in the Cooper's ligaments, all of them. And the pathologist says, you are right, it went down all the way to the nipple. Let's look at the details. This area has these pictures. Is it DAB? Yes. Calcification? Not one. Desmoplastic reaction, lymphocytic infiltration? Oh, yes. So let's look more. Well, that's the invasive, but it's a mixture of AAB and DAB. And this one is right here. No TDL use. You know the rest so well. Look at this. Cancer factory. A previous examination didn't show anything. Did I tell that the cancer was no, I didn't tell that. So now you see the mixture of AAB and DAB, very visible DAB high up in the axilla, too many ducts, too contorted. I can entertain you as long as you wish. Now we go for the left breast. And the left breast had not only this, what the MR found, but also here, a large area with carcinoma, non-calcified. That's why it was negative on the mammogram. It practically goes down to the nipple, that one too. Strange disease, isn't it? She actually had multiple AABs, but this is a surprise. On the right side, it was 8 centimeter DAB. On the left side, picked up by MR, mostly because of this, not this one. Also, this one goes practically to the nipple.